So good evening all, and welcome to the second session of the webinar series organized by the Department of Health Professions Education by Kaka University. We are truly privileged to have you all with us this evening. And today we are going to have a discussion on one of the important topic, especially for health professions. So that is interprofessional education and collaboration. So to deliberate on this topic, we have our esteemed speaker. Let me take the privilege to introduce and welcome the speaker of today's session, Professor Dr. R. Harihara Prakash. And I'll be briefing about sir's profile before handing over the session to sir. So sir is currently serving as principal and head of KM Patel Institute of Physiotherapy by Kaka University. He is also a member of the Department of Health Professions Education and the Director of Internal Quality Assurance Cell at Baikaka University. He is also serving as an adjunct faculty at MAHE's FAIMER Institute, Manipal, and a paid team member of NAC and UGC. He hails from Pondicherry with over 28 years of rich experience in both clinical practice and academics. And sir has also held various prestigious roles in universities and professional organizations across India and has contributed extensively to physiotherapy education and practice. Sir is also a FAIMER Fellow in Leadership in Interprofessional Education and Practice and a committed advocate for disability rights and inclusive healthcare. And apart from education and practice, sir is also a yoga enthusiast, a passionate cyclist, and the founder of the cycling club at Baikaka University. And sir has also received various awards for his excellence in service and practice, which includes Rashtriya Vidya Saraswati Puraskar, IAP Oration Award, and several Lifetime Achievement Awards and Research Excellence Award. Sir has also a keynote speaker and conducted various workshops at various conferences across India and abroad. So now I would like to welcome Professor Dr. Harihara Prakash to enlighten us on the topic interprofessional education. Over to you, sir, and hope that we will have a truly engaging interprofessional discussion here. Over to you, sir.
Thank you. Yes, thank you so much, Shani, for giving me a lengthy introduction. But one simple word, if I have to say about myself, I'm a learner still in the field of healthcare education, trying to capture many things from my mentors, from colleagues, and even from juniors, patients, and students. It's a great platform for me to share whatever I had learned from my mentors. And the topic which has been given to me for this, or which I have chosen when our DOHP department asked to deliver the webinar series number 2, I picked up this interprofessional education and practice, the way forward for improving global health. I got exposed to when I got my FAIMER fellowship selected in way back in 2017 with MAHE FAIMER, where it is exclusively for interprofessional education and practice, where I got introduced to this terminology. When I say terminology, because this is something new term for me when I got into this FAIMER fellowship, though silently we have been practicing in the healthcare field, trying to collaborate with people, but not understanding the competencies, the concept and everything. So when I got introduced to this FAIMER fellowship program, and it was really an eye-opener, and I understood the concept with lots of clarity. And that's how it has helped me to have my journey moving on in trying to work for improving the local health, global health, and all those patients whom we interact day in and day out in our OPD. So let me start. Is the slide moving, right? Yeah. Okay. So let me just place in record my heartfelt gratitude to my mentor, Dr. Himanshu Pandya, who is the Dean of Medical College, where I got my nomination recommendation to get into FAIMER Fellowship. And most importantly, to my MAHE FAIMER team, Dr. Siraj, who was my mentor. And I'm highly privileged to have Dr. John Gilbert, who is here with us in the online mode. Very good morning. I guess it is morning for him, and he has taken out time to be here. It's equal to having hundreds and thousands of people listening to the webinar of mine. So it is a lifetime achievement for me, where I learned from him and I'm trying to deliberate in front of him. Pardon me, John, if I miss some concepts and you are there to really add on some more inputs to the talk which I'm trying to deliver with my people over here. And next is to my university, the Department of Health Professional Education, Dr. Sarmishta Ghosh, who is the head leading the DOHP with us, for giving me this opportunity. So I place in record my heartfelt gratitude and thanks to Shani for introducing me to the audience. So this is our campus. For those who have joined online who have never been to our campus, so I extend a warm welcome to all of you. This is our campus, Baikaka University Shri Krishna Hospital, which is a 52-year-old organization, which was started by our late founder, Dr. H.M. Patel. This place is the birthplace of Sardar Vallabhbhai Patel, which is called as Karamsad. So it's having a medical college, nursing college, physiotherapy college, lab technology, and many more, and have our NABH accredited 1150-bedded hospital where we could able to really practice IPE and IPP, since we have multiple programs under the banner of healthcare education. So I welcome you all for this campus whenever you get a time, and we'll try to invite you all when there is a scope to have. This is our campus. This is all our infrastructural facilities. Okay, so without taking much time, let me just come in directly to the objectives of this discussion. I'll be defining IPE and IPP, but many are probably newbies to this terminology. So I'll just give an introduction and give a background about why IPE is gaining such emphasis in this present scenario, and what are those competencies which are essential to practice IPE and collaborative practice, and identify certain strategies where we could able to integrate this into our clinical setting. So I made it very simple since it's an introductory lecture, and it will be with some examples and explanations. So you can stop me if you have any problem. So the opening slide is that you have seen this photograph many a times when you were in school. You can see an elephant, and you can see blind people trying to identify what it is. This is a common story which we used to hear in our childhood days, but now I relate it with this healthcare education, health profession education. I'll be happy if somebody unmute and share what is the missing link in this. Anybody, if you have time, because I can spend some 5 seconds to 10 seconds wherever I wanted to invoke some of your presence to interact with me. So I'll be happy if somebody wants to share. What is the missing link in this picture? Anybody? Or what comes in your mind when you see this picture? It can be the other way. If not the missing link, when you see this, what comes in your mind? What comes in your mind immediately? What strikes your mind?
May I, sir?
Yes, please.
Sir, so all of whoever is present in the picture, they have their closed eyes.
Yeah.
So they cannot identify an elephant as a whole, but
Hmm.
they are identifying the different parts. So
Yes.
until and unless you see together with open eyes, you will not be able to identify the picture as a whole.
Exactly. So well, that's nice of you for coming up and opening up with an answer, which sets the stage for me to move further. So now, if I ask you what is the missing link, so that you can identify this as a whole picture, you mean to say how to open eyes? That's one answer. You mean to say?
Open eyes, and then all of them they need to integrate the answers together.
That's right. Okay. Thank you. Thanks for the response. So it is all about teamwork and communication. Even if they are all blind people, so it is very difficult for them to have the vision. But if they communicate amongst themselves that this is like this is like that. So if they try and establish a good teamwork and communicate amongst themselves, probably the whole picture they can identify, not as a rope, not as a fan, or not as a they can identify it as an elephant. So this is something which we have to keep it in our mind whenever we talk about IPE and IPP. So there is some small activity. I want the participant to either go into menti.com and enter this code, or you can directly scan this particular QR code and try to elicit the responses. Is the QR code visible to Shani? Is it visible? No, you could able to open, and
It's
the code
visible,
is
sir.
also there, menti.com 52447256.
Sir, I think you have stopped the slide sharing. Okay.
Oh, Just a sec, I'll do
The
that.
QR code is gone.
Oh, sorry. I'm just coming back again. Just a minute. Yeah. Is it visible?
Not yet. It is there, but it is in the slide.
You can even directly.
Yeah, it's coming.
Quickly.
It's coming. Yeah. Open browser. Yes.
The menti.com, it is
Yes, sir.
52447256.
It's coming.
You can start giving your responses. We can see in the word cloud.
Healthcare professionals involved in treating diabetes.
Diabetes. List the healthcare
Yes.
professionals involved in treating diabetes. There may be some 4 responses which you can write and submit it. Yeah, I could see physiotherapist, physician, nursing. Wonderful. Medical specialist, orthotist and prosthetist, health educator, nursing surgeons, dietitian, lab technologist, doctors. Yes, I think good. This is enough for me to elicit some response. I think you could able to identify multiple healthcare professionals, physicians, surgeons, medical specialist, physiotherapist, medicine, endocrinologist, orthotist and prosthetist, and health educator, lab technologist. Very nice. So the workload, you can keep giving the responses. I'll go back to the original slide to take you up to the next thing. Yeah. Thank you. Thanks for the response. So if you understand that one disease, you have multiple people have to come together to give the best of care to our patients. So in that case, so how can we work together? Because you have medical endocrinologist on one side, physiotherapist, rehabilitation nurse, orthotist, prosthetist, So this diabetes management needs so many people, pharmacist to psychologist, social worker, because the complexity of the disease, there are a lot of pathies, diabetic neuropathy, diabetic retinopathy, nephropathy, hepatopathy, encephalopathy. There are so many pathies that, if these people doesn't come together, it becomes difficult to treat these problems. Otherwise, finally we have to land upon sympathy only, because the patient goes nowhere, he could not able to get the right therapy. So here comes the role of a team, where we identify each and everybody works together. But the present scenario in many of the places, these people are working in silos. They are not coming together. The doctors feel that we are the one who leads the team, and sometimes the nurse feels that we are the one who are actually and directly were dealing with the patients, and sometimes the pharmacists take a lead that without me you cannot provide medicines, and dental people talk that we have. So everybody, they work in silos. They try to have a strong professional identity that my profession, and I am the leader for all these things. So in that case, working in silos never gives the results which we are expecting to treat. Diabetes is one such example. You can take many such conditions where more than one professionals come together and work. And this is taken from the FAIMER Regional Institute. Annie was a 2-year-old when she lost her life after a pharmacy technician filled her IV bag with more than 20 times the recommended dose of sodium chloride. So, what is the reason for this? Where was there anything wrong in the cycle of communication between the physician, the nurse, and the pharmacist while prescribing, while administering, while dispensing? This has costed a life because there is some lack of communication, or the teamwork is missed out, which has costed a life. So Ramanov in 2002 has told that if healthcare providers are expected to work together, when we say these conditions need multiple professionals, we expect them to work together so that they can share their expertise in a team environment. It makes sense that their education and training should prepare them for this type of working arrangement. So we have to ask this question: how can they work together if they don't learn together? So IPE precedes IPP, interprofessional education, without which interprofessional practice is going to be a difficult job because they have never been taught together. So this was identified way back in 2002. We are now in 2025. The framework WHO, which gives, you can see the local health needs in the present scenario, it is completely fragmented. People are scattered and they are working in silos. But the future we want is IPE. When we introduce this interprofessional education at the college level, where a nurse, a student, a nurse student, and a physiotherapy student, and a lab technology student, and a medical student sit together and understand their roles and identify their needs, each other's needs. When they do, and when they have the education done together, you create a collaborative practice. That the task force which is going to, for the futuristic optimal health services to provide, we can strengthen the health system. So by having this IPE and IPV, the arrow mark, if you see the top end, is improved health outcomes. That's what we expect, that we want to give an improvement in the global healthcare. Even this Institute of Health, triple aim is also talking about it, where we have this population health on one corner of the triangle, experience of care, and this per capita cost. We want improved healthcare outcomes. So among the population, it's the population health, and we want to enhance the patient experience of care so that we can reduce or at least control the per capita cost of care. So all has to happen simultaneously. So we are planning for prevention, promotion, curative, and rehabilitative. All has to happen together so that we can reduce the per capita cost of care. So this can happen when this teamwork comes together. That's what this Institute for Healthcare Improvement talks about. So for this, what are all the competencies which are all needed? There is a paradigm shift in the healthcare practice. So previously, decades before, it was physician-centered practice, but unfortunately, sadly, in many places, still it is dominated by what the physician wants to prescribe. Same is like it is like in teaching, it is teacher-centric, very less student-centric. So we want to move from physician-centric practice to patient-centered care. And rather than practitioner autonomy, we want team collaboration. So we don't want to focus only on illness and cure. We have to focus on wellness, health promotion, prevention. And patient as a passive role should not be there. No more it should be. We should involve the patients and families in decision making. We call it as shared decision making. And it is not alone for acute and episodic care. We have to care for chronic conditions so that overall life expectancy improves with good quality care. The quality of life of the individuals have to improve. So this interprofessional education, the definition, the picture itself gives you an understanding, occurs when two or more professions learn about, from, and with each other to enable effective collaboration and improve health outcomes. So when we were in the FAIMER class, I still remember John is on the other side of the camera. He always says that interprofessional, there is no hyphen between inter and professional. Even that hyphen should not come between inter and professional. With that much amount of closeness should be there. So interprofessional is together. The education should happen where they learn about, from, with each other. So the logo is this: the learning with each other, learning from each other, learning about each other. So it's an example. A medical student learn with a nursing student. The medical student learn from a physiotherapist. The nurse learns about an orthotist and prosthetist. So it is that with, from, and about each other. Learning happens with each other. Learning happens from each other. Learning about each other. So we understand the whole perspective of the need of an individual who is having suffering. Or even for that matter, as I said, health promotion also needs collaboration. So the practice is when multiple health workers, again, the medicine, nursing, etc., and so on and so forth, from different professional backgrounds, work together with patients, not alone patients, it is the families or the caretakers and the whole community to deliver the highest quality of care. So when we say this highest quality of care, it needs collaboration. Working in silos can give some symptomatic relief. The patient may feel better temporarily. But if you want a continuum of care, if you want them to have highest quality of care, collaboration should happen, because it is so many people plays a role, as I shown in one of the slides: retinopathy, nephropathy, neuropathy. So it is not one man's task. It is multiple professionals. They have to work together for the betterment of the person or the community at large. So again, I reiterate, where it is again learning with each other, learning from each other, and learning about each other. So they both are interdependent. Interprofessional education, if it is there, interprofessional practice, if you are practicing it, as I said, before till 2017, though we understand what interprofessional practice, we used to do it, but Formally, when I learned through this MAHE FAIMER program, MPhilippi, we understand that interprofessional education, the concepts, the clarity, and the competencies, which will make you have clarity in how to move further in a team. So the practice spectrum is moving from uni-professional, that is working in silos, to multi-professional, interprofessional, and trans-professional. Again, I would like to knock the door of people who are sitting on the other side. Can somebody unmute and share what does these 3-4 terminologies means? How do they differ, or how do they differ from each other? Uni-professional, multi-professional, interprofessional, and the future is trans-professional. Can somebody unmute and talk about and can share their thoughts on this, what it is? Anybody can volunteer yourself, whatever comes in your mind. Again, I'll wait for 5 to 10 seconds if anybody wants to share. Okay, with the interest of time. So we all know uni-professional is silos, me, myself, my work, multi-professional, more than one profession come together. But the missing link over there is that if you remember that elephant and blind people going around, there is no communication, say the work. Again, uni-professionals working in silos, but for the common cause. Interprofessional is what we are talking about, where we need collaboration, and trans-professional is furthermore, there is the boundaries are dimmed. There is no difference between orthotist and some people, they take up the role of a nurse to take care of the patient. A doctor can take the role of a nurse. Sometimes the nurse can take the role of a pharmacist to deliver the things, understanding the concept, having that is what is trans-professional. Even a layman takes part in the decision-making process. That is the future. But why are we talking now? Why this topic has propped up in these years? It is the reason that there is a shortage of 4.3 million health workers worldwide. It is the health is no more the responsibility of only doctors or healthcare professionals. We want multiple people to come together to promote health. To give an example, when I got introduced to disability component of my FAIMER project is also on disability. It is, for example, a person who is having locomotor disability, who cannot able to climb the stairs up to reach a target to his classroom or to the clinic. So the doctor, the orthotist, and the doctor can prescribe a splint or a walking aid, and the orthotist can give a splint for that. But it is the architect who need to create a ramp instead of having a stair. Here comes the role of an architect who provides the ambulation and inclusiveness to reach a target. Mechanical engineer create an artificial joint to replace a damaged knee joint. So there is role of nowadays these app developers, IT professionals play a major role. So the health is no more just responsibility of doctors. We need more people to come together. COVID was the best example. The police force came in, and then the sanitary workers came in. Public refrained themselves moving out of we could able to combat COVID. It is just not only the healthcare providers who helped to come out of the COVID pandemic. So if you see, there is need for more people to understand the need of health of a person. Health is just not only absence of disease, it is promotion of good health, for which we want more people. And what is there? There are lots of network globally. You have this Canadian Interprofessional Health Collaborative, where John Gilbert is the pioneer in this. Nordic Interprofessional Network, Japanese, Australian, European. There are the countries, they are talking about it since many years, right from early 2000s. This is all there in practice. What about India? Where are we as locally we are placed? I think to my knowledge, this is FAIMER, the first institution which developed this independent, the Indian Interprofessional Education Network, where you could able to collaborate. This is, I can Google it and you can see the role, and there are people already united, and Dr. Siraj, who was the founder director of this. So MAHE introduced this Interprofessional Institute for Leadership in Interprofessional Education, which is there in Manipal. So where the goal should be across all the settings. There should be a dialogue between the patient who is getting treated in the acute care to primary care to rehabilitation care. So we want a seamless care for the patient. We call it as continuum of care. All the health caregivers see themselves as part of the patient's care team. So there is communication. If you see the arrow marks, there is communication between acute care to rehabilitation care to primary care. And it is also that the patient and their family are getting the right support when illness strikes. So there is no I in the team. Healthcare professionals who perceive themselves and other healthcare professionals as part of a team working collaboratively for patient-centered care. It is, again, as we saw in one of the slides, it is moving from physician autonomy to patient-centered care. There is no I in the team. I leads to illness and W leads to wellness. If you want to promote wellness, we have to collaborate rather than being I as there is no I in the team. So this picture you can see where in IPE, it is to enhance learner outcomes, where the learner is at the center and educators are around and the professional beliefs as an institution, the attitudes over there are certain micro factors and certain macro factors and meso factors where these institutional factors influences the educational system to promote IPE. And that will help the learner to have good outcome so that he can enter into patient-centric care where we want this learner who got educated and under a setting with IPE to practice IPP. That will enhance the overall outcomes of the patient. So there are lots of values. There are so many things which has to come together to promote this. It's an evolving framework, though it dated back in 2004. Still, we are trying to do that collaborative practice and interprofessional education to come into existence in many parts of our country. And the roadmap is there, but the journey is so long. We have to really take a long way to achieve this. So now that I have introduced the terminologies, I have given you the understanding about what IPE and IPP is to make you understand, though I have taken this diabetic as an example, let's understand through a case scenario, which will make my job easier and your job easier to understand. Let's take this condition, complex discharge planning for an elderly patient. So the patient, let's assume she is Mrs. Sharma, an 82-year-old woman admitted to the hospital after a fall resulting in a hip fracture. She lives alone, has early stage dementia and limited family support. She also has a history of poorly controlled diabetes and hypertension. So this is a common scenario in many of the hospitals where you see such complex cases. A geriatric 82-year having a hip fracture, poorly controlled diabetes and hypertension, only single person in the family, no one along with her, no family support, and having early stage of dementia. So this is not uncommon. We see in tertiary care hospital. The challenge here is we need to ensure a safe and supported discharge plan that addresses her physical recovery, and she is being so we have to take care of the cognitive decline that she has, chronic condition like diabetes and hypertension, and social needs to prevent readmission. So there are so many things as the patient has this complexity. We need to plan a discharge for this elderly patient. So now you can understand, having this case scenario in front of you, let me take you to the next slide where it is going to give you a clear picture. The team involved, who are all the team who are going to take care of this lady, Mrs. Sharma, who is 82-year-old. The primary role is played by the orthopedic surgeon, where he need to operate and maybe he goes for a replacement or a surgical procedure to repair. And second, we need an internal medicine fellow, the physician, who we need to take care of the diabetes and hypertension so that the patient is stabilized, has stability overall throughout her hospital stay. And the role of a physical therapist, where he or she comes for improving the strength of the person, improving to bring in mobility, safe ambulation, and before discharge to look into the home environment so that we provide her, as I said, an example of staircase if it is so, we need to create a ramp or grab bars, the toilet seat, another thing. Occupational therapist role, where the ADLs are taught to her, the daily grooming, dressing up, undressing, with again maintaining the cognitive function so that she's safely doing that. And dietitian, because 82-year lady with diabetes and all, she need to assess the nutritional status, provide education about the diet that she need to follow throughout her life, and importance of calorie intake so that the problem heals. And the action, that is the team, and now how they are going to work together, that is what is very important. Before I go into the competencies, I'm giving you how this team has to work together. First is daily team rounds. We call it as IP round. It is possible. Interprofessional round. The nurse, the surgeon, the physician, the physiotherapist, occupational therapist can discuss about Mrs. Sharma's progress, identify the challenges, and adjust the care plan collaboratively, where people discuss amongst them. The first thing is that when the patient is in the wards, we do a IP round. Second is the goal should be set in a shared way. The common goal for safe, supported discharge, we agree on some realistic short-term and long-term goals. As the patient discharges, what are the short-term goals? And as she goes back and get herself community integrated, the long-term goals. And the third important thing is that communication, as I shown in the previous slides, regular updates should be provided for each discipline. I have given an example, the PT, the physiotherapist informs the occupational therapist about mobility progress so that this occupational therapist can give proper activities of daily living planning. And then joint assessment and consultation. So they have to do a joint home assessment example, simulation, and discuss what are the equipments we need to give a cane or a walker or a crutch, whatever, the medical team has to consult the social worker regarding mental capacity for decision making. So there should be a patient and family meet. That is why it is family-centered care, where if there is some caretaker who has brought in the neighbor or somebody there, or if possible, the patient herself, they should have the relevant team members where they explain their roles, propose the plan, answer their questions, whatever if they have, ensuring everyone is on the same page. All these things should happen together. And the last important is problem solving. If Mrs. Sharma refuses to participate in therapy, the team collaborates to understand the underlying reason. Why is it so? Why she is not ready to lift the limb? Why she is not ready to come out of the bed? Why she is not doing weight bearing? Is it the pain which is giving her the problem, or the anxiety, fear, or the understanding because of cognitive decline, dementia? So we need to do a unified approach so that we encourage her complete participation so that the outcomes are much better. So this slide is very, very important. When we talked about the team involved and the action plan, we need certain competencies which we have to learn when we are working as a team. The first and foremost competency is the team-based practice, where we have to collaborate, come together, understand. So we need to know who are all the people who need to be part of the team. Sometimes the orthopedic surgeon plays a lead role when the patient is going to be operated. Once when the rehab comes, sometimes the physiotherapist take the lead. When there is some bed sore or other complications, nurse take the lead. So the leadership rotates over here, and we have to identify the team members. Second, the best communication practices. In Annie, because of overdose, the death happens, lack of communication. So when the patient is handed over to the next thing tomorrow, if you want the patient to be ambulated, the doctor wants the physiotherapist to strengthen this limb, there should be a proper notes. It can be verbal communication, written communication. The communication plays a key role for successful outcome of IPP. And the next important is role clarity, roles and responsibilities. Because many of us has a strong professional identity. I am the team leader, I have to be doing this. So if someone encroaches the domain of others, there is always a clash. So we need to know the domain specific activity. We need to limit ourselves. This is my role, I have to do. Rest I communicate with the other person. He comes and play his role. That's how the roles and responsibilities for collaborative practice has to be very clearly explained as one of the competencies. And the next and the last important is values and ethics. We need to follow those. So this continuum of care gives a proper practice trajectory. Having all these things, it is community and population centric. So it is values and ethics, roles and responsibilities, team-based practice, and then communication. These things are important competencies to be followed. So this is the core values which the collaborative practices. Values and ethics for interprofessional practices: work with team members to maintain a climate of shared values, ethical conduct, and mutual respect. And for communication, communicate in a responsive, responsible, respectful, and compassionate manner with team members across. And the roles and responsibilities, as I mentioned earlier, use the knowledge of one's one role and team members' expertise. That's how learn from each other, learn with each other, learn about each other. So we know the expertise of the other person and give the responsibility to the other person so that we address the individual and population health outcomes. And the team and team workers apply values and principles of science of teamwork to adapt one's own role in a variety of team settings, because too many people coming over there. So it has to be very clearly framed. So if you ask about are there evidences, yes, there are lots of evidences as far as interprofessional education is concerned. It increases the understanding of others' roles, skills, responsibilities, overlap in knowledge and skills, altered stereotypical views, enhances team working skills, better sense of how interprofessional collaboration and communication skills grow and develop, which is there in the paper by Cooper et al. And Reeves et al. So there are evidences again. So this reduces the less fragmented services. If you collaborate, the fragmented services get strengthened and we can go for a holistic way. Better access to services and shorter waiting times because all are on same page. So the waiting time reduces better communication, better patient outcomes. The decision making becomes collaborative, more appropriate referrals, improved safety, which is very, very important, and quality, and increased level of critical thinking among health professions, higher levels of well-being among staff, greater retention of staff because we work together, and reduced hospital admissions and duplicity of services. So this quality IPEP promotes safe, effective, patient-centered, timely, efficient, and equitable care to our community. So these are the key points through IPP we could able to achieve. But having said this, there are lots of barriers. First and foremost is time. When we say that, how do we collaborate? When should I have my lecture plan where I can learn from, with, and about each other? There are structured, rigid curriculum. The NMC gives certain rigid curriculum, INC gives certain, and now we have this NCHP. This act always restricts us to go have more of academic flexibility. And second, there should be some rewards or money. People expect, why should I go and teach other healthcare professional about my job? Competing curricular demands, logistical issues. We need to have a classrooms or such arrangements where people sit together and learn, or practice, and lack of trust. When I share my knowledge, when others sees it, what will happen to my expertise? And this strong, one side we want professional identity, but in this present scenario, we want interprofessional identity. I identify myself as a medical doctor or a physiotherapist or a nurse. At the same time, I have this interprofessional identity. I know I don't want to work in silos. I want more people to be in my team. So I identify myself as an interprofessional member of the team. So we need more such things. We need more evidences, more research outcomes. We need to have good competencies based IPE. We need to develop curriculum. We need to have such programs where these competencies are incorporated. We could able to create good modules on IPE, which this FAIMER MAHE fellowship program really takes up lots of projects where such competencies are identified, such modules are designed, validated, and applied, and set across, institutionalized. We need to identify champions who practices this, so that we take, like how we have John Gilbert as a person pioneer behind this IP and IPP. We look forward, we listen to his talk. We have lots of literatures coming out, which is going to help us to understand the concept. And most importantly, we need administrative leadership. You and I wanted to do this, but your dean may not be, your management will not entertain all these things. We need to have good leadership for this. We need to have faculty development programs. Such webinars are certain eye openers for so many people. We need to have receptor sites in practice. We need to identify such teaching moments, such learning moments where this IPE and IPP can be prompted. So I think 7:45, 7:50 it's going to be. We have another 10 to 15 minutes. I gave an example through a case scenario, and I have some 20 plus people over here. Let's do an activity again with a simple case scenario. And I request the participants to, unmute and talk, or use the chat box if you have some limitation in opening and unmuting and talking. Let's do an activity. It's again a case scenario. Please understand and give your responses through chat, or I have almost come to an end. So with the time limitation. So this is all about stroke rehabilitation. We know this cerebrovascular accident is a neurological condition. So Mr. Patel, a 65-year-old man, admitted to an inpatient rehabilitation unit. So that means acute care has been done following an ischemic stroke that resulted in right-sided weakness. We call it as hemiparesis, expressive aphasia. He's having difficulty in speaking, and swallowing difficulty, which is dysphagia. So this is the condition: 65-year-old man having an ischemic stroke, hemiparesis, which is a motor problem, aphasia, he can't able to communicate, could not able to swallow the food which is given. So the challenge over here, which is identified, is maximizing Mr. Patel's functional independence. Having this right-sided weakness, we want to make him move around, improve his communication because he can't able to speak properly. Aphasia is there, expressive aphasia is there, and we want to ensure safe swallowing. Otherwise, it will cause regurgitation or pneumonia. Sometime aspiration can happen. So we want to prevent complication and facilitate a successful return home. So this is the challenge, like how we saw in that 82-year-old woman to manage diabetes and hypertension. Here, we want this Mr. Patel to have functional independence, prevent any complications, and improve his communication before he gets discharged to his home. So now I want three things over here. Please identify who can all be the interprofessional team members. Whom do you want to be part of this team? You can list down or you can speak out, you can use the chat box. And what is the line of action? You identified healthcare professional, 1, 2, 3, 4, 5 people, whatever the number that I wanted it from you all. Second, I wanted that you have to, what is the line of action? Like this team, what they will do. So over to you all. I would be happy to get your responses. I'm waiting for your responses. Anybody, if they want to unmute yourself, you can unmute and please, you can talk. Take this as an opportunity to speak, and others can use the chat box. I'll
I
wait
think
for.
Yasho has put something in here.
Yeah. Yes, ma'am. You can read for me. Yeah.
Okay. He says that team,
Ha.
internal medicine specialist, voice therapist, surgeon to take care of swallowing, pharmacist, community health worker, and physiotherapist.
Wonderful. I think she has listed down many. Good.
Yashovardhan.
Yashovardhan, yes.
Yashovardhan, yes.
Yeah, Yashototala.
He was recently down in our campus. He's one of my CHP students.
Oh, right. Okay,
Yep.
Yashovardhan Tota. In
Okay, so
Totala,
then
he has
after
given
that we
Tota.
have physician, physiotherapist, neurologist, speech
Yes.
therapist, critical care specialist by Farooq, nurse, dietitian, surgeon, speech therapist.
Yeah, critical
Then
test.
we
Yeah.
have Azra and mostly common neurologist, physiotherapist.
Right.
Then Anusha, ICU specialist, nursing team, ENT, physiotherapy, OT,
And
speech therapist.
I think wonderful. The team members almost has been are identified. That's
Yeah.
great. So let me take you to the next. Then we'll go for the line of action. Where the time limit. So
Kinza Zeb, after the webinar, could I get the certificate? No, this is not a certificate-oriented webinar. This is simple learning.
learning experience, yeah.
Yes.
The certificate is that you learned something new. That's it. So the
Exactly.
interprofessional team, I have prompted it in front of you. In many areas, we have this physiatrist. Most of the time, he manages the condition. Since it's not an acute care. Acute care, you need critical care people. You need surgeons. Here it is next care, tertiary care or rehabilitation setup where this physiatrist, the PMR fellow, does it. As you all rightly pointed out, physical therapist has the role to improve the motor skills. Yes, occupational therapists, many of you have mentioned where this activities of daily living needs to be promoted. And the speech therapist, or we commonly call them as medically speech language pathologist. So he helps to make this person have expressions, receptive language deficits can be improved, communication skills can be. And then this, even they recommend appropriate diet textures so that the tongue movements are enhanced. Then we need to have a rehabilitation nurse because she's the one who maintains the skin integrity and reinforces therapy times, monitors the vital signs. We need to have social worker because as the patient gets discharged, they are the one who integrate the hospital setup with the community setup. They are the listening people. And neuropsychologists, sometimes it is needed because these people, cerebrovascular accident, they lose memory. Sometimes they have attention deficit and sometimes emotional problem issues. Sometimes I know they have this behavioral problems. And of course, dietitian because the nutritional needs to be met. So these are the team members which you have rightly pointed out. Now I wanted this direction of action. So like if you recall the previous case scenario, think on that line. So now we have people, we don't want them to work in silos. We want them to collaborate. So to collaborate, what are the action plan which needs to be there? Like I shared over there, and that if you recall, we need to have daily rounds, we need to have communication. Just recall all those things. I don't want to prompt. You can speak or you can unmute or you can put in the chat box. Go ahead. What should be the line of action for this IP team? You have identified the IP team, which is the first thing you have been successful in identifying who are all going to be. Now, what should they do? Please think on the competencies which we have talked about. I reiterate roles and responsibilities, communication, ethics and values, and team planning. Please go ahead. If anybody wants to unmute, please, you can unmute and speak to me. Okay, teamwork, software to communicate. Okay. Nee, I wanted how this action plan, what they are supposed to do. People are there. We have some 17 people, and what we want them to do. Go ahead, please. We have 5 more minutes. Is my question clear? We want the action plan, what we want this team to do for getting the successful patient outcome. Anybody interested in speaking to me on unmuting yourself? Okay, I could see Yashovardhan. First team meeting for discussion about the patient and line of management. Okay, very good team meeting. Informing the family about the plan of action that has been decided. Very good, where we wanted to have a shared decision making, connecting the family to a social worker and community health worker for social needs. Perfect. Follow up through either facility or home visit. Wonderful. And Dr. Anusha has given grand round once a week. Yes, cross references, referral services, counseling a patient, relatives in a team. Perfect. Great. Furthermore, can I have more responses? I have 1 more minute. I can wait. Counseling, continuous communication until improvement. Again, that communication plays a major role. Yes. Right. It's 7:55. So let me prompt the answer. The interprofessional practice, as rightly told by Dr. Anusha, weekly team conference. The entire team has to meet weekly so that they can check the progress, identify the barriers, adjust the therapy goals, and strategize the discharge planning. And integrated therapy sessions, because we don't want the physiotherapist come once in the day and go, occupational therapist coming sometime and go, sleep language. So we want them to come together. For example, I've given over here, the speech language pathologist might work on communication during an ADL task led by the OT and PT, so that these exercises can be incorporated along with. Wherever possible, the team can come together and offer the therapy session. And communicate, many of you have already mentioned consistent communication strategies. We need to interact so that the team members collaborate amongst themselves and they try to see the progress of the patient. And unified dysphagia management, as when dietitian comes and play a role, there what type of diet has to be given, the speech language pathologist and dietitian come together. And this home visit, Dr. Farooq have talked about, or somebody else have mentioned it, where they make a simulated home environment in this place. They visit the house and see how this house is there, at the potential barriers needs to be avoided. We need to recommend the modification so that the patient seamlessly enter the house and could able to perform the day-to-day life activities. Family education, where that whole team provides consistent education to Mr. Patel's family about the condition, prognosis, because we need to set the realistic short-term goals, long-term goals, and offer them the next follow-up visits. And we need to demonstrate the exercise therapy programs which the patient has to follow at home. And next is most important is problem solving, behavioral issues, where this psychologist comes and plays a major role, where they develop de-escalation strategies and coping mechanism. So this has to happen collectively so that the patient understand. So the key elements demonstrated in this scenario, if we try to list it down, like how in a qualitative study we take out the themes and codes, in this condition, the first and foremost is patient-centered care. So we are, by collaborating, we are trying to establish patient-centered care. Shared goal setting, that's the second important thing. Third, mutual respect and trust. As a team, when we are working, the values and ethics there, where we respect each other's role, we trust a person's caliber and the expertise. Effective communication is the next key area which should be demonstrated. And collaborative decision making. We all come together, identify the patient's needs, prioritize the patient needs, which is to be important. So that particular team member will play his role. So it's a collaborative decision making. Then furthermore, role clarity and flexibility. So as we prioritize, sometime it may be the communication skill which needs to be prioritized. It may be sometime the ADL, the activities of daily living needs to be. So we need to be flexible in arranging the therapy sessions and understand the role of each person. And next is accountability, because the problem when more than one person come together, too many cooks spoil the broth is an English language, where who had put the salt in the dish. It should not be like that. We need to have established good amount of accountability, that this is my job, I'm doing it along with this person, I take accountability of this particular activity. So accountability many a times gets missed out, and the blame game starts. I didn't do it, he came and did it. That's something we should be careful. And problem solving approaches, and continuity of care, because we want the patient to seamlessly exit the hospital with a proper strategized exit plan with a discharge summary, so that the patient goes back to his place and continue his services. So these are the key elements which are all identified through this IP action plan. Let me go back and read it quickly. Patient-centered care. These are all take-home messages in sort of shared goal setting, mutual respect and trust, effective communication, collaborative decision-making, role clarity and flexibility, accountability, problem solving, and continuity of care. So we need to understand that we are getting everybody on board. We will not leave any stone unturned for improving the global health outcomes. That's the most important take-home message, where we need to identify now no more silos, no more uni-professional, it is interprofessional. We as healthcare professional should identify ourselves as a team member of the interprofessional team, where we can be more successful by collaborating ourselves with our fellow colleagues. And beyond our healthcare team, as I said, architect plays a major role. Sometimes mechanical engineer plays a role. Sometimes a housekeeping faculty plays a major role. So we need to identify the roles of each people for bringing the better outcome for our community. With this, I think it is exactly .8. I have adhered to the time. Thank you so much, and God bless everyone. Let us all come together, work together for the betterment of the community. You can reach out to me through the WhatsApp number which is here. If you have any questions, feel free to write to me. I'll be happy to share the documents or any literatures. I am happy to get, Dr. John has given already a good article which I'll share it in the group. Thank you so much. Over to the organizers, and I'll be happy to take any questions if we have time, or else we can write up. Over
Thank
to
you very
Dr.
much.
Samshita.
Shani, you can wind up. If
Yes,
anybody
shall we
has
wait for a minute
any
if anyone wants
questions,
to?
any
Yeah.
burning issues, I see John waving.
He's clapping to
Yeah.
me. Thank you so much, John. Your presence made
Thank you
my
so much.
anything you wanted to add on, please. We'll be happy to hear some words of wisdom from you as a closing remark. If Dr. Ghosh permits, one or
Yeah,
two,
of course.
two lines from you, because
Two
it is
lines,
like
yes.
listening from harsh mouth. Me speaking
I
in
know.
front of you is nothing. We would like to hear one or two lines from you. Please, over to John Gilbert.
Well, thank you. This is a very interesting, very complete presentation. Just a couple of things. The definition was changed to include services. And actually, you have alluded to services in your talk, but I think it's important when you're thinking about definition with, from, and about, collaboration, care, and services. Because we can't forget that the word interprofessional is not specifically about regulated professions. And you alluded to that in your almost final comment. There are others who are engaged in the care of a patient beyond, the usual clinical settings. So it's useful to remember that those services we sometimes forget in planning. And I was curious because I didn't see a pharmacist very much. And the case of Ms. Sharma, I thought was terrific. The two cases were terrific. And we need to understand the team, the interprofessional team within that those frameworks. I think that we are moving a long way to try to understand what it is to be interprofessional. What is the professional identity that we are trying to develop in our students? And so my line is, you can't really be interprofessional before you've been a professional. You have to understand your own role, but we have to think carefully about, so what is this thing, this interprofessional thing? And you kind of were working your way to it in terms of identity. And there's a lot of work being done on that now, as you probably know, by Jan Jaap in the Netherlands and my colleague Sherry Price at Dalhousie. And we're trying to get a really good fix on that, because once you have the identity, when you have that interprofessional identity, everything becomes much simpler to understand in terms of interacting with other members of the healthcare team. And, the hierarchical issues become much less. The problem, as you've alluded to, Hari, is, we do have this hierarchy, and getting rid of the hierarchy is what makes us move towards interprofessionalism. So thank you. It was a very, very interesting presentation. I think you covered all the bases, but please, please, please use the Canadian Interprofessional Health Collaborative framework on competencies, because it's not a check. The American one tends to be a checklist. Ours is not a checklist. That's why I put that little paragraph in the message that I sent you.
Right. I'll read. Yeah.
Competencies should not be checklists. They should be methods of acting. You know, how do you bring the patient and the team together? So the interaction piece is really, really important. But thank you very much for inviting me. It's been great to see so many people online. And of course, it is the evening for you. So go away and have your dinner. I'm going to start my day by going downtown. And I today will be welcoming in person probably 200 new Canadians. I will admit them as new Canadians. So that's my pleasure this morning, to welcome new Canadians to Canada. Because believe me, there'll always be a Canada, regardless of what you hear elsewhere. So thank you all very much.
Thank you, John,
Thank you
for the
very
words of
much.
wisdom. It was really
Thanks a lot.
services. I'll make a note of it and I read those points which you have given. Thank you so much. This really ends with a good closing remark from you. Thank you so much. We appreciate
Thank
this.
you, and thank you for
So
inviting me.
any of you who have questions, you can get in touch with Dr. Harihara. And I think Shani will just give one line concluding remark, and then we can all
Ma'am,
log
there is a
off.
question in the chat box, sir. There is a question, sir. Please explain trans
Trans-professional, yes, I
Okay.
think Aarti, yeah.
Yeah, see, transprofessional, as I said, it is one level next to interprofessional, where these sort of barriers as a nurse, as a physiotherapist, and that gets completely blurred. You know, people seamlessly take up the task and try to act. It is role clarity is there, but still we understand the need. For example, I'm a physiotherapist. I understand the role of a nurse because I have learned from the nurse that is what is learning from with and about each other. I want to give that service. So I take over diligently with the guidance and I perform that so that the patient is not deprived of the need. So we go beyond our boundaries. That's how the boundary is blurred over here. It's not a rigid thing. I am a physiotherapist. I am a medicine fellow. I am a nurse. It is beyond the trans. Across. Trans means it is across. You seamlessly go through so that the patient care is kept in the center and we try and play the role even beyond our expertise by understanding from the co-professional. I hope I'm clear.
Okay.
Yeah.
Okay, Grishma. Grishma has something.
Yes, Grishma,
Thumbs up,
please.
I see.
Okay.
Yes, Grishma? Okay, maybe that's my mistake.
Okay.
Okay, so I think we can.
Sure.
So there is one more question. How to tackle hierarchical culture and shift from I to we?
Shift from
Particularly keep aside
I to
personal
we,
interests,
particularly,
egos,
yeah.
and interpersonal
Okay,
relations.
I to we. Okay,
I
that.
to we.
Okay.
Yeah. Yeah, as John taked, hierarchy really plays a major role in Indian scenario, not alone across. So this needs real that's why we need to identify champions. We need to gradually enter into this interprofessional work where we identify others' role. So we need to have role models. We need to have such sessions where we try and establish in a small level. We should try and work within our limits where I could able to perform. So, or we need to take the hierarchy, maybe the dean or the head of the department or the superior to you, we need to talk to them. So, as you have written very correctly, we have to keep aside the personal interest and ego. It is all about patient-centric care. When John always says in the big team, where is the patient? We have the patient is the major role who is in the center. So when we have the patient in the center, rest all things goes away because we prioritize the needs of the patient. If it is a swallowing difficulty, it is this and that. So that we try and give space for our co-professional to work together. So this will come in practice. We need to initiate somewhere, baby steps has to be taken, identify champions and try and promote this. Maybe gradually the change will, it's not an easy task, whatever. That's why though it is all from early 2000s, still in 25 years down the line, we are struggling to establish this. So for that, you have to, as you said, mentioned, interpersonal relationship plays a major role. We need to have collaboration. We need to have sessions together. So IPE is important. Education, let's start education first. So practice follows.
Okay, Vyoma has a point. This requires faculty and student sensitization, which is very true actually.
Yes.
People have to first recognize the need and then only they will practice what is expected.
Absolutely.
Okay.
So practice is better than preaching. So we need to set an example rather than
Right.
preaching.
Absolutely. Okay.
Great. Thank you.
Okay, Shani.
Yes, so I think I'll conclude now if there are no more questions. So as we are concluding, I take a moment to thank Dr. Harihara Prakash. So it was truly an enriching and interactive session. And as the discussion goes on, it's truly difficult to implement. But I think we should have a starting point. From there. We should initiate such things. So thank you so much, sir. It was really wonderful listening to you. And I thank all the participants for your time, your attention, as well as your interaction. And have a good evening. Thank you all.
Thank you.
Thank
Thank
you
you,
so
everyone.
Thank you so much. Thanks a lot.
So, Shani, you keep the recording open so that it gets saved. You stop recording, so it will get saved in your laptop.
Yes, ma'am.
Okay, and then
Sure.
So thank you so much from my side to all
Thank
of you for patient listening, and thanks to Dr. Ghosh for giving me this opportunity.
a
Again,
marvelous
Shani, for
talk.
introducing.
Yep.
Thank you. Thank you all. Thank you so much.
Let's
Bye-bye.
take care.
Stop
Have a good
recording.
evening.
Thank you. Very good evening.
Yeah, you can stop recording.